dimensions of wellness, something that we haven't done a lot of programming around in the past, but financial awareness and concerns being one of the 8 dimensions. So this is something that's new for us that we're trying. If you're interested, if you have questions, please let me know. There is a yellow sheet in front of you, comment cards. As you know, I take your comments and your feedback very seriously, so any suggestions you have for improvement, I appreciate hearing those. And the green slip, if you're interested in receiving credit for being here, or if you are interested in, Katie, do we have another blanket?
We do.
And receiving or winning, having a chance to receive a Agnesian blanket, register, fill out that green slip and send it down to the right, pick it up later in the program. One other thing that's on your table this afternoon is just a blank white slip. And that's out there to remind me to ask you for some help. We've been doing this programming for over a year now, and attendance in the last number of months has dipped a little bit. Today's attendance is pretty good, and I think it's Steve's star power that's brought everybody out. But that notwithstanding, I am looking for your feedback on what we can do to improve attendance at these sessions. It's really important that we have enough people that, in order to ask a presenter or a provider to come and talk about what it is that they do, if we don't have a room full of people, it's kind of hard to make that ask. So if it's programming that you find valuable, and if you think this is something that we'd really like to see continue, please give me your feedback on what we can do to increase attendance or change a program to better fit whatever scheduling, etc. We'll take a look at anything that we can, and I do appreciate whatever it is, feedback that you have to provide. So now I'd like to introduce our presenters for the day. We have Steve Little, of course, our President and Chief Executive Officer, and Dr. Mike DeGeer is here with us as well. Familiar faces to us. Dr. DeGeer is the Vice President of Population Health Management for Agnesian HealthCare, and you may have seen his presentation during the forums. And both Steve and Dr. DeGeer are members of the IHN Integrated Health Network, which is our accountable care organization. They're both members of the board of IHN, and they've been very active for a number of years now. Steve chairs IHN's Finance Committee, and Dr. DeGeer is active in the Clinical Integration Committee. So they're both very involved in these 2 of 3 of the standing board committees at IHN. So they have a lot of information. They're involved at the ground level, so any question that you can dig up and throw at them, I encourage you to do so. So with that, Steve.
Thank you, Holly. Good afternoon, everyone. See some eating lunch, some don't let this interrupt your lunch, please. As long as it's oh, so good. Did you hear that? A healthy lunch. Right, Janelle?
Yes, sir.
Amen. Amen. Thanks for the reflection, Holly, and getting us going. My purpose today is to introduce you to accountable care, and then the star power, Holly was wrong, really comes in Dr. DeGeer because he's a lot more credible than I am at a lot of these things, and he's a lot more enjoyable to listen to. So with that, Mike, the standards are set high. I just hit the wrong button, didn't I, Colleen? Yep. Got you going. We're okay? We're good. All right, so this accountable care, as you will come to know, is ACO. You hear that term a lot. Who's the ACO? Who's the ACO? Just remember that. Accountable care organizations and ACO. Where the heck did this come from? And the simple fact is that it was born out of the Affordable Care Act, otherwise known as Obamacare. And I was thinking about that earlier. I mentioned it to the session at 8 o'clock. So is Obamacare going to be called Obamacare when President Obama is not in office anymore? I mean, it's kind of like Hillary Care. We talked about Hillary Care back in the 90s. We still call it Hillary Care. So what do you guys think? Still Obamacare? Uh-huh. I suppose. By the way, Affordable Care Act has had lots of ramifications on our country. And I won't comment good, bad, or otherwise. But something you should be aware of today that's going on is the King versus Burwell court case that's at the U.S. Supreme Court. Anybody familiar with that in the room? Show of hands. 1, Dr. Salasek and Evan. That's pretty impressive, Evan, for a bean counter. Yeah, right? So for those of you who aren't, it's no disrespect or you haven't missed anything. However, what you need to know is it's really important because it has the ramifications to turn the Affordable Care Act upside down. And how it can do that is somebody found a loophole in the law, in the Affordable Care Act, that states, meaning physical states in the United States, to say state one more time, that have federally funded insurance exchanges, of which Wisconsin has one, right? Our government said, no, we don't want to run the state insurance exchange. We want to let the federal government do that. If you have one of those, and there are people in the state of Wisconsin that are being subsidized for their health insurance premiums, that may be against the Internal Revenue Service code, and it could flip this whole Affordable Care Act upon its end. So pay attention to that, because I can't remember the exact amount, but I think there's around 80% of the people that access health insurance through the exchange in Wisconsin are getting some form of subsidy. And so if those people are disrupted, it could have major ramifications. So keep your eye on that, just as a side note, all right? So many of you have heard me say this, that the federal government has a budget problem. We all know that, right? We're running at a deficit. We're spending more money than what we are bringing in revenue in the federal government. And it's some phenomenon. I don't even know what it is anymore. Anybody know what it is anymore? What the federal deficit is at? It's at trillions, right? I mean, it's absurd. And my comment is, no, we don't have a federal budget problem. We have a health care problem, right? And that's known as Medicare, all right? So accountable care organizations came about through the Affordable Care Act because the government is spending way too much money on health care. Medicare consumes, or I should say healthcare in general consumes almost 18% of our gross domestic product, which is what we spend as a country on everything. And the closest developed nation to that is somewhere in the 10% range, but we won't get off on that topic today. So here's the problem. You in this room fund Medicare, right? You get that, it's right on our paychecks. Every pay period we get a deduction for that, right? And the federal government has said, uh-oh, we have all of these people, Jim Salasek, Molly, I won't pick on you, Barb, Sister Mary, that are coming off the payroll here in the next number of years, us baby boomers, right? And then we have these millennials and these, what's the other group? Gen Xers, which is younger. The Gen Xers are younger, right? Yeah. Older, so the Gen Xers are like 48 to 30-ish, and the millennials are the 30 and younger. Say that again?
That would be our age.
Yeah, right. Yeah, say that again, Dan? Gen Xers, okay, we won't debate that today. But the problem is what? The baby boomers, which I'm at the very end of that, by the way. I didn't know I was a baby boomer till recently, but I am. They're the single largest portion of our population that we've ever had, right? And so guess what? We don't have enough Holly Brenners in the room in the United States to fund us that are going to use Medicare in the future. So, we better figure a way out to be more accountable for our care, right? So what is an ACO? And we can read this. An accountable care organization is a network of doctors and hospitals that share financial and medical responsibility for providing coordinated, huge point, coordinated care to patients in hopes of improving quality of life and limiting unnecessary spending. That's it. End of presentation. I hope you have a good rest of the day. Really, it's that simple, right? It's that simple, but we haven't been able to figure it out because that's difficult to do, right? So why did Agnesian HealthCare join an accountable care organization? The real fact of it is that we had nobody in-house that knew what an accountable care organization. I told the group earlier, I remember when Bob called me and said, hey, we're going to meet with Freighter next week over at Marion University, Bill Potosnik and a few others, and we're going to talk about accountable care. And he goes, you know what that is? And I said, well, sure, Bob, that's just being accountable for care. And he goes, no, like these new accountable care organizations that are in the Affordable Care, have you done any research on that? And I'm like, I saw it as a word, but I have no idea what it means. I mean, it's pretty straightforward. We just need to be accountable. What does that mean? Well, none of us knew what the heck was going on. And by the way, neither did Bill Potosnik at Freighter and others. Nobody knew what this thing was. The other fact is that we lack scale. To be an accountable care organization, we felt that we didn't have a broad enough geography, we didn't have enough people, we didn't have enough financial resources, and not to mention we didn't have the expertise. Furthermore, I talked about geography. We thought, well, you know, we only serve, if you look at our total and catchment area, people that we serve, it's about 100,000. And we're not sure that that's a big enough population to be able to be wide enough and broad enough to be effective, all right? The other thing was that we thought we needed to be linked to somebody that was more credible, even though we deliver unbelievable health care, and you know that. But the perception is academic medicine is always on the cutting edge, and we better be linked to something like that, right? So, and lastly, this was always been my opinion, and I'll explain a little bit more later, that we lacked ownership of an insurance company, because ultimately when you're accountable for care, you're going to be taking risk. You're going to be guaranteeing someone that you're going to provide a certain amount of care for a limited amount of dollars, and if you exceed that, you're going to be at risk. Have we ever done that at Agnesian HealthCare? Not in my time here. I think we did have some affiliation. I'm trying to see if there's any old timers in the room that were on that side. I think we did have something in accountable care or in managed care that we took risks, but not much. So we're not very good at that. But that's what insurance companies do every single day, right? So to have some affiliation with an insurance company would be important. So why did we choose Integrated Health Network of Wisconsin, by the way, which started out as Quality Health Solutions, and about 2 years into it, we found out that somebody else somewhere else had that name, and we went, uh-oh. And so we debate, I mean, it took us like 6 months to figure out the new name, and anyways, we won't go into that whole thing. But when you have 7 health systems sitting at the table, sometimes it's difficult to make decisions timely. So why did we choose them? Simple fact, we had a relationship with the Freighter and the Medical College. We've had that for a long time. And they were a catalyst in this, so it made sense for us to come along with them. They were a logical choice for us. And oh, by the way, it was the only choice. There was nobody else. Seriously, when we started talking about this, and this has been almost 4.5 years ago now, there was nothing else. That was it, okay? So who is IHN and where do they live? All right, today, or I should say initially, it was Freighter at the Medical College, and they have always been the catalyst, all right? You should know that. Columbia St. Mary's, Bellin Healthcare, Theta Care, Aspirus, and Agnesian. Those were the original systems that came together years ago out at Marion to say, how is this going to look and what are we going to do? Today, that has evolved, same Freighter, Medical College, Columbia St. Mary's, added Wheaton Franciscan, added Ministry Healthcare, added Hospital Sisters Health System, which is, you know, St. Nick's and Sheboygan, St. Mary's, St. Benny's, St. Clair's, not St. Clair, Sacred Heart in Eau Claire, et cetera, and Agnesian HealthCare. So what happened to Bellin, Theta Care, and Aspirus? We had to make a strategic decision on who we wanted to serve the Fox Valley and then to the west. Bellin, Theta Care, and Aspirus serve essentially the same geography as Ministry Healthcare. And we voted collectively and unanimously to bring Ministry Healthcare into it. Why? Because they had an insurance company, network health plan, right? Very key to us taking risks. They can help us with that. And that was the driver. In addition to that, at the time, Ministry Healthcare has had a very tight relationship with Marshville Clinic, and that's deteriorated. Breaking news, who saw Tuesday that this group has one more member? Anybody know who that is? Come on, aren't you reading the paper? Or I shouldn't say that. Who reads the paper anymore, right? Aren't you looking on the computer to read the newspaper online? Maybe it's not that broad. SSM HealthCare of Wisconsin, better known as St. Mary's in Madison, Dean Health Plan and Dean Clinic, has joined this. Gee, why is that? Why did SSM join us? Not far. The point was they don't like UW, right? That's not far off, because who's the other competing accountable care organization? Anybody know who that is? Oh.
About health.
Katie, you've already been to this. You can't answer that. Katie answered it. It's called About Health. That's an interesting name, right? And Dr. DeGeer will talk to you about health. And that is made up of UW. Bottom line for us at an Integrated Health Network, we did not have geography, and Dr. DeGeer will show you later, in that Madison area. So to have coverage in that area for our network was very important, and SSM was a logical choice. So you can see that us Catholics have surrounded the Frederick Medical College, and I told Kathy Jacobson recently, I said, all you gotta do is, convert to be a Catholic system, and we could form this giant conglomerate Catholic system in the state of Wisconsin. She didn't necessarily like that. Anyways, be that as it may. Integrated Health Network is located in Brookfield, Wisconsin. My truck drives automatically there. I've been down there at least 100 times in the last 6 months, and I'm not kidding you. We are there all the time for meetings. And they have about 82 full-time associates, so it's grown into a fairly large organization, all right? And with that, Dr. DeGeer is up. This is why you really came today.
Thank you.
You're welcome.
Good afternoon. Thank you for coming. My part of the presentation I would like to dedicate to hopefully communicating why this is impactful, meaningful. Why does it matter to me and my job? Why does it matter to you and your job? How does what we do every day factor into the decision to be in an ACO in the first place? So some of you have seen a talk recently at the forums on population health, and you may have seen a slide just like this. And I want to preface this talk with it, and I'll start this portion of the talk the same way I'll end it, with the most important part, which is right here in the middle of these intersecting circles. Agnesian HealthCare's mission, vision, and values. Why do we exist? Where are we going? And what do we agree on is important to us in order to work together to get to those goals? So everything that we do at Agnesian HealthCare is based on our mission, vision, and values. So these things that we do for population health need to serve this mission, or they're the wrong objectives. So we're confident in the mission, vision, and values, so all these things need to speak to it. The accountable care organization fits into this sphere, the managed populations, the contracted populations that we take care of. We'll get into what that means to us moving ahead when we talk about metrics and measurements. Our greater communities, where we live, where we work, our region, our geography, and our associates and patients' well-being, the people we take care of. That includes us, that includes our patients of our hospitals and clinics, and all together, these are examples of how we manage population health. The Accountable Care Organization fits into here, and that's the subject of today's talk. So to look at the map on the right, all the shaded areas are where IHN, our ACO, is represented today. Because SSM Dean just joined us, we'd have a larger shaded area down here, which would also pretty well match shaded areas on the other side, the other ACO, where they have coverage too. So all these systems together, while independent of one another, work together as a teamwork to create a network and collaborate. So together, thousands of physicians in IHN, hundreds of clinics, dozens of hospitals, and you already know the players involved at SSM Dean. So this is where we are today. You know where we are, us, Agnesian HealthCare, we're here. But this is where we are as an ACO. So About Health also has some of the players you saw in the initial talks for the ACO that we are a member of today, and some others. So Aspirus, Aurora, Bellin, Gunderson, ProHealth, ThetaCare, and UW Health. So if you know the geography of where the people in our ACO are and the geography of where the people in the other ACO are, you get a feeling for the market and where each of these teams are located today. So why does it matter to us? Why is this even important work to do? Why get involved in one? You heard some of the reasons in Mr. Little's portion of the conversation. When we look at this, we say, well, all right, how about at a clinical level? What does it mean to me as a provider? What does it mean to my wife or my kids or any patient who may come into this? Why is it better for us? Well, on the organizational level, by having member systems at the table to talk about, all right, what are we going to do? The last few years have been foundational, formational. What are we going to do? Now we're turning the corner on how are we going to do it? It's time for accountability and execution. So how we're going to do that, we actually have to measure our work. How we measure our work comes from sitting down at the table and say, let's look at our numbers. Let's see how we're doing in each of these categories that we have agreed are important enough to measure and be held accountable for. So discovering what are, or sharing what are best practices for a specific disease condition, for example. Looking at the scorecard, saying, here's the measures that we're hitting versus the measures that you're hitting. You're a little bit better at that than we are. What's your secret? Without reinventing things, saying, here are some things we put into place that makes it easier for us to hit the metric over here. So getting around the table, sharing best practices, and, of course, from the competitive side of things, it puts us in a better position to compete because we are not just Agnesian HealthCare, we're part of a larger network. So the next few years, I just mentioned that we are now moving to the action phase. It doesn't mean it's going to be all figured out right out of the chute, but it's time to show our work and be held accountable for it. How much do we spend on healthcare, and are we as good as we say we are? Here are the numbers that show that we're as good as we say we are, or that we have agreed with the payer that we will be good at. So today, we live in fee-for-service world, which also is tied to utilization. Order a test, by and large, patient gets the test, by and large, you're paid something for the test. Doesn't always work out that way, but it's a per-click situation. Exams, CT scan, MRI, another exam, return to the office, hospitalization, surgery, you name it. So this is how spending can get out of control, because everything has a price. This has a price too, that you also determine ahead of time. We're going to take care of this population of patients for X amount of money, and we're going to be really good at the quality measures. Both are going to happen. And if both don't happen, it's why that word risk is there. We stand to lose money. Different types of arrangements. There's upside arrangements where you say, I'm going to show that we're good in this, and we're going to also show that we're going to save money at it. And if you do that, there's a bonus for you. Upside. Downside is don't do those things unless money comes in, period. So we need to get better at managing the health of populations and controlling the spend. And if you do the first, you should be able to get the second. So how do we do that? As we turn this corner into the action phase, something called a care model we're looking at. Actually a map of our priorities, accountable parties, resources needed, and all the work groups, the subcompartmentalization of the work that we're going to do. And we'll look at what those mean in a slide or two later. The good news is this isn't brand new to us. When we look at what's important, and we agree as a collective of ACO organizations, these are things that we at Agnesian HealthCare are already doing today. What's different is we are putting it to paper and measuring it in ways that we share with one another, including these other systems. So breaking it down into smaller groups, each organization, Agnesian HealthCare being one, has representatives in the focus areas, or these work groups, and each of the other ACO organizations also has their roster of people. So when these folks get together in person or on the phone to talk about quality, pharmacy, inpatient, readmission, care navigation, orthopedics, and depression, the work groups of today, they have their roster of people too. And ours is bigger than this. These are some representation that you have in the room today, and also some leads that have been on the work for quite some time. So when we get down to the how are we going to decide what best practices are, folks get in the room and talk about things in their areas of expertise. So it's not arbitrary. The days behind us are this is what works well in my hands, or in my experience, this works well, or patients seem to do pretty well when this happens. That's not evidence-based care. Evidence-based care relies on data, volume, multi-center look-backs at what works well. That doesn't mean that individualized care is gone. There's always going to be the need for that. It's not prescriptive medicine, but it's deciding together what do best practices look like so we have a better chance of maintaining the health of these populations we take care of. The work groups are really the level of what are we going to do, how are we going to measure it, and then it moves up through the scorecard formation. Other things outside of just those work groups, end-of-life care strategies, chronic condition management, which is a big part of what population health is. We talk about disease management. How do we take care of folks with heart failure or COPD or diabetes? So disease management, population health management, you can think about them in the same vein. We just spoke about clinical evidence-based guidelines. Post-acute care. Our responsibility for the patient extends beyond the hospitalization. What do we do in those situations? And I'll give you a concrete example of how the work we do at the ACO has helped in that realm. House calls, things you don't hear about too much anymore. Thing of the past, possibly a thing of the future, because taking care of people in the environment where they live, between episodes of medical care, is becoming as important as what we do at the episode of medical care. So we're going to need tools to do that. Again, we can't just go on a feeling of, I think Mrs. Jones needs this, or she's probably due for this, or let's order this. We can't just be arbitrary. So we need tools that help us to organize our work and to tell us how we're doing and to tell us who might be at risk. In general terms, you do have a more specific form on your desks today, the white 8.5 by 11, that talks to some of these tools and how they're used. So Crimson, think of that as a care management tool that defines the risk of the patients. Valence, data warehouse for the information. And Healthy Intent and Healthy Registries are things that we're using here at Agnesian HealthCare to make the information more timely for the providers who need it. So we'll go through a couple of examples of how that looks on a provider level. So Cerner's Healthy Intent is a population health platform, a tool that we've just started using in January here at Agnesian HealthCare. And we hope to use examples and what we learn from this to lead at the IHN, the ACO level, say, here's what's working for us. Here is how we're getting our data quicker and more meaningfully, and taking care of the patient in a more holistic way when we know they're coming in the office or whether they're before us. So this is a fictitious example. Roberta Williams, MD. Dr. Williams opens the chart, or opens Healthy Intent and says, all right, how am I doing on the measures that we are keeping track of nowadays? Up here we've got foot exams, 12% met. Well, okay, I gotta remember to include that foot exam. I've got depression screening, I'm at 14% of target. And you can see here, 54 persons remaining. So tools like this are much more helpful to a provider to say, you know what, I've got to build that back into my workflow. But without these reminders, it's easy to just go about your day doing good work, taking great care of people, but if meanwhile someone's keeping track over here and that's how we're measured and paid, it would have been nice to know, while the patient was in front of us, what might I have done differently? So there's a lot of information in the electronic health record today, but if it's put into a format that is usable, doesn't take another 30 minutes to do, and takes care of Mr. and Mrs. Jones when they're in front of you is the goal. Excuse me. So, healthy registries are taking certain diseases or certain collections of priorities and putting them in one place. So if a doctor is taking care of patients with diabetes or patients with heart failure or depression, there are registries or collections of measures within that process that apply to it specifically. So if a patient comes in and is being treated for diabetes, there are things you might want to be treating specific to diabetes. So let's take a look at what that looks like. This is an example of a patient, James Barnes, again, fictitious, comes in, and now the provider has Healthy Intent open to the person of James Barnes. So James Barnes, there's a few things we're watching for James. Nurse might open this beforehand and say, let me run the clinic list, who's coming in today, what are things we can take care of even before the provider walks in the room. There's things we could set up, gaps we could close, so that when the provider comes in the room, everything is very focused and efficient and doesn't feel rushed. And the patient knows you're taking care of all of me, not just the one thing I'm here for today. So if you looked at this and said, all right, certain things are performed, certain things are still waiting, or certain targets aren't where we'd like them to be based on the ranges that we've agreed on are important for us to stay into. So looking at each of these, performed, documented, still waiting, not met, 2 out of 5 met, these types of tools gives the provider a real-time look at how can I take the best care of this patient for the reasons we have collectively agreed are important. So, if you're a patient or a provider, is being in an ACO a good thing? It's a good thing if it's working in the way that it's designed to work. And that's where we have some work ahead of us to do. To get things coordinated and integrated across systems in a way that is actually meaningful to patients and providers is the whole key. As we approach risk with our contracts, we need to get good at it because we have a lot of skin in the game. We're going to show we're good at it, and we're going to show that we can control the cost of care by keeping people well. It's a lot less expensive to stay well than to keep getting sick. And that is the goal with population health management. That is the goal with the work of the ACO. So to have a structure in place where we can look at a patient's set of conditions or circumstances and say, Mrs. Jones could use more help around her, or Mrs. Jones isn't sick yet, but will be soon. There are predictive analytical tools we can use to say, will be soon if we don't put things with her to help her. So providing a structure where we can know we're applying best practices and getting the sick well and keeping the well is the goal. So let's talk about specifics so it's more real. That was my goal and what I hope to provide with this section of the talk. So let's talk about things we've done for the ACO that actually meant something to people and to us who work in healthcare. So at Agnesian HealthCare, 64-year-old cancer patient was identified by the Crimson data system as needing navigator assignment. What does that mean? It means this patient is at risk for having problems, and because of this collection of data, she needs some outreach to see if there's other things that need to be put in place. Check on her is the message from the system. So, Mrs. Jones, how are we doing? Once we make that contact, follow-up issues are found. Deconditioning, pain management problems, labs are off, significant medication reconciliation issues. This person is on the path to having problems again. So I titled this Staying Ahead of Hospital Admission because on her own, through no fault of her own, Mrs. Jones is at high risk and getting riskier for reasons that we can mitigate. So a navigator, somebody who helps the patient to identify with the patient what these care gaps are and what we can put in her home or around her as a support system can improve her situation. Home health, big one, right? Bring the care to her home rather than the patient to ours, right? We can do that here too, but not best for Mrs. Jones. More costly. Other things can happen when you're hospitalized. People get sick in the hospital too, right? So if we can provide home health services, and that's a key gap, we want to provide that. So through these interventions, effective and efficient management of her symptoms. Pain's under control, it wasn't. Medication reconciliation has occurred and wasn't. She didn't end up in the ED, but probably would have, and wasn't hospitalized. So the goal of care management, transitions of care, putting support systems around patients includes keeping them in the outpatient world healthier, rather than needing us on an acute level in the inpatient world. So how about at the point of where a person works? Oh, I just saw a bunch of checklists, I just saw a big grid, there's so much more work to do. Is it more work? In a way, it can be, because right now, we're not there yet. So you'll see another example where we're learning retrospectively, there are gaps to close. But why is it even important? Back to the first slide. Does it serve our mission or doesn't it? I put this in here because it's exactly how I feel. It better. Everything we do better serve our mission or we're doing the wrong thing. Either the thing we're doing is wrong or the mission is wrong. And we're solid here. Mission, vision, and values, we've got them. And we agree we're going to live by them, we're going to work by them, and everything we do is going to be tied to them. So, compassionate care. Delivering hope, health, and wholeness to all under our care. Does that just mean when you're sick, we help you to get better? It absolutely means that. But that can't be where it ends. It also means continual care of the well. That's taking care of one another as well. So, more work, work for the right reason. The work we do, the work we've agreed is our mission to do. So our work in the ACO, while in the beginning you feel like, okay, it's work group, it's assignments, it's things we have to do to close gaps, it can actually change the way we approach our own work. Remember a few slides ago, these are things that we already do today. It may change the way that we approach them so that we can offer them in a better way, more convenient, more accessible, more timely way. In the clinic, we talk about episodic care, or in the hospital, episodic care. Doctor's visit to doctor's visit. Emergency department, back to emergency department, hospitalization to hospital, episodes of care, working on panel management, taking care of people all the time who are under our care. Or a provider may say, these 500 people are my patients. How am I managing, helping my patients, empowering them with education and resources to stay well? That's a direction that we're moving, which our ACO work helps us to acclimate to. And predictive analytics, reaching people before they're ill, putting tools in their hands, putting support around them to get them well again or keep them from becoming more acutely ill. That can change the way that we actually approach our work. So let's talk about a few of the things. We looked at a few of the work groups before. So what does it mean on a work we do every day level? The depression work group is one of the newest in our ACO, but we know it's super important, and here at Agnesian HealthCare, under Dr. Salasek's direction, we are moving it forward and serving as a leader among organizational groups because this is very, very important to us. Why is it important in the first place? This isn't me, this is the CDC. 9% of adult Americans are living with depression. 1 out of 11 adult Americans are living with depression. I always say, when we're talking about adult Americans who have this, or 1 out of 11, we're not talking about them. We're talking about us and them. This is all of us. This is important to people in this room. This touches people in this room, our families, our patients, everybody in our region. This is a real situation that we have to address. So we recognize if we're going to treat something, there's 2 parts to that, 2 big parts. You've got to find it, you've got to identify it, and you've got to provide access to the interventions that will help with it. It's not enough to know, yes, confirmed. We surveyed everybody, and it's true. It's 1 out of 11. What now? Is help on the way or not? So looking at, let's find a screening tool. Let's be consistent with how we do it. Let's use the very best one. And once we have the information, let's speak to it. So that's what we can do on the depression level as an example. If we develop it here, we can take it to our ACO partners and say, here's what's working at Agnesian HealthCare, for example. Pharmacy level, medication therapy management for outpatients. A pilot group has started with a few of the ACO partners as a start to say, how are we going to look at the highest risk outpatients and help them with medication? Example a few slides ago of a patient, significant medication reconciliation issues. Things we think they're on don't match the things they're on. They've got 3 bottles of the same pill. A lot of those things can happen. Didn't pick up the medications, we think they're taking it, they're not, and so forth. Start with the highest risk, but it's not just about taking care of some of our patients, it's about taking care of all of our patients. Start with the highest risk, longer term, spread the intervention and support to moderate and low risk populations. So it's just the way we take care of people. Mammograms, one of my favorite examples for you today. Right here on a down-home level. Bill Daly, you know, headed up this initiative, and it's got real numbers attached to it that I think are very impactful. Starts with, how does this relate to the ACO? Well, last year, the quality work group, they had a contracted population of patients under a contract where there were measures in place that we had a chance to earn more money, upside, by showing controlled cost and had good quality of care. Well, mammograms on time is one of those quality of care metrics. The work group looks at it and says, a lot of women who were due or overdue that didn't get in for their mammogram, partly because they may not know they're due for one. So, a call list was developed. Call all the women that are due or overdue for their mammograms and encourage them to come in for a mammogram. Well, this resulted in some key information. 2 of these women that were called in for a mammogram, who otherwise would not have probably had it as timely, or perhaps at all, were diagnosed with cancer. So when you say, does running a list make a difference? Huge difference to 2 people who had cancer and would not have otherwise known it. It underscores the purpose of screening for breast cancer. But rather than finding out we're behind on mammograms, catch it up and then make it part of the way you do your business to make sure those who need a mammogram not only know it, but have access to it in a way that's easy for them to accomplish. So that's where we change the way we do our business here from work that started with an ACO initiative. This is a screenshot from the Agnesian HealthCare website. I know it's hard to read from the back, so I'll read it. This is the breast health area. Here's where we are today, as in the last couple of months since this started. We are proud to offer same-day mammograms at all of our women's imaging locations. No need for an appointment. Walk-ins are welcome. We're open from 7:30 to 4 p.m. That's different than, Mrs. Jones, we'd really like you to come in for a mammogram. How about 2 Thursdays from now at 2 o'clock? Mrs. Jones works. I just took off for another medical appointment 2 weeks ago. Doesn't work for me. How about 3 Thursdays from then? What are we doing? Mammogram's getting farther and farther away. How about instead, we'd love for you to come in for your mammogram, or you're due. Would you like to go over and get your mammogram right after this appointment? If they're already in front of a provider, or how's tomorrow? Or how's later tomorrow? What works for you? Any takers? You bet. Over 150 women have come in since the middle of January for a walk-in mammogram. 150 plus, because you changed the way you provide access to the care that you have asserted is important for you to provide in a timely and effective way. That's a big deal. That is different than chasing down people that are overdue. It's letting people know it's time. How's today? Tomorrow? Next Tuesday? You decide. Please do make it a priority. That's a difference maker. So we are learning through all this that reminders can help. They help the patients to know, oh, didn't know mammogram was due. Didn't know this was colonoscopy year. All right, that helps. Helps providers too. A lot to juggle in a patient appointment. Sometimes they're coming in for something completely else, right? That happens a lot of the time. And if you're focusing your time on that appropriately, that's why they came in. But we miss taking care of the rest of the patient for lack of having something in front of us to remind us. We want to close that gap as well. So we've learned that access and convenience makes a difference on all these fronts, for the provider, for the patient. Getting well and staying well is the entire goal with population health management. It's the goal with ACOs. If we have better health and better care and lower cost, those are all wins on the ACO and contracted level. It's also a good way to run your house. You will not spend as many healthcare dollars if you are well. Those who are well, some spend almost none, right? Other than their healthcare premiums. They're just paying those premiums because just in case, but taking care of things in a maintenance way, in a scheduled way. And then there are others who just keep coming back into the hospital. Keep coming back into the hospital. Not the patient's fault. Is it the disease process's fault? The disease is the disease. We need to use best practices to help the patient to manage these, to stay well. Staying ahead of acute illness, taking care of the whole person who's before us, that we have committed to assist, and sticking to our mission. It ends the way it began. Everything that we do has to speak to the mission, because we have agreed the mission. Why do we exist? If what we're doing doesn't speak to why we exist, you have to ask the question, why not? So everything we do, including being a part of this team known as Integrated Health Network, speaks to our mission, or we wouldn't be there. So just wanted to frame it in that context. I think it's the most important context. It's what we've committed to is important to us as an organization. I thank you for all your work, and we left plenty of time for questions if you have them. Appreciate your attention.
Fire away, yes.
How is the ACO supporting panel management? Is that a best practice that we're absorbing?
So the question is, how is the ACO supporting panel management within practices, et cetera? Dr. DeGear, you're probably best to answer that.
Well, moving to panel management is something that we have identified as something that we want to do. I think part of the planning process as it relates to the care model we were speaking to is saying, if we're going to do panel management, we spoke to what resources is that going to actually require. Sometimes it's more resources than we have here today. So as an example, IHN can contract or spend money on resources that we have agreed are necessary. A certain number of FTE, for example, per member system to help do panel management. So on one hand, the ACO can contribute to the cost of that, or an organization may say, this is what we need to do on our side too. So it's definitely part of the equation.
Janelle?
This question kind of involves my husband's health, for example. He works out of the county and he's able to use Agnesian as his provider they're in the, same network as we are, but Radiology Associates is not. He was notified that he can no longer use them, and that's who Agnesian uses for those services. So, for example, he has a lot of kidney stone issues. He has to come here every 6 months. Now he can't get his KUBs and ultrasounds and things done here unless we're gonna pay, the out-of-network costs.
Mhm.
So is Agnesian thinking about using a different provider than Radiology Associates, or is there someone in the network, because he looked and he couldn't find anybody, because he wants to stay here with his urologist and nephrologist, but he may be driven out?
Yeah. The answer to the question is very simple. Are we looking to contract with other radiology professionals? And the answer is no. We've been with Radiology Associates of Fox Valley for quite some time. They do amazing work here. That's an insurance issue, and what your husband needs to do is go back to his insurance provider and say, I need you to have these people in network. Radiology Associates of Fox Valley provide services at all 3 of our hospitals, Theta Care, Ministry, the Affinity Systems, etc. So they are widely accepted throughout the Fox Valley, and they provide the bulk of the care here. And so he needs to go back to them and say, hey, these are quality people. You need to get them in network. That's going to be your best solution.
They're not in the About Health network? Are they in the IHN group? That was the problem, I guess, that they were with the Theta Care system, so they're in the About Health.
About Health, and he's got product that's narrow through, no, he can't. You and I should follow up on this, okay? Rather than take the rest of the group's time, because it's really an insurance question versus an accountable care question. You and I will visit you now. Others? Yes.
Do you think the ACOs will stay regional, or will they eventually go national?
Oh boy, we had that same question this morning. And it's really whose crystal ball has the clearest lens, and I don't know. I would say today, based upon the state insurance regulations, that for the time being, meaning the next 1 to 3 years, it's all going to be within the state. In fact, it's going to take us, years, months ahead to get our act together. Anyways, does it have the potential to go nationally? Yes, I think. Within 5 to 10 years potentially, but it gets more and more and more complex, and it really gets back to those darn IT folks, Cliff, Tiffany, on us being able to have a national health information exchange of which providers can access your health information anywhere in the country they are, and we're many years away from that. But stay tuned. Yes.
So are they able to access our health information in this system?
Yes. Easily? No. That is going to be the single largest barrier, I told the group this morning, to us having success with an integrated health network on a timely basis. We do it. We push all of our information into integrated health network, and we use Valence and we use Crimson to manage your care effectively. But it's another spot that you as caregivers have to go to check to see if Lori Cardinal had an event at Freighter, at Ministry, at Columbia St. Mary's, etc. And it's not always as seamless and easy to use, right, Dan, as what we would like. So for me, what's going to be instant success for us is that we all need to get on the same platform, and Katie Tank needs to have one patient medical record identification number that is consistent at Freighter, at Columbia St. Mary's, at Wheaton, here, Mercy, etc. If that's the case, then as soon as Dr. DeGeer logs on to take care of a patient, there's Katie Tank. She's been here, 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 here. She's had this, and this, and we can coordinate care in a greater fashion. So that means we all need to do what? Everybody else on Integrated Health Network is on what? Epic. So we need to move to Epic. Hey, Carla, no. The reality is that ain't gonna happen, at least in the near future, because we've got $100 million plus buried in Cerner, and we're not gonna walk away from that investment. And there are things about Cerner that are better than Epic and vice versa. But somehow we've got to figure this out. Now, there is a thing called FHIR, and this is a new technology for you IT gurus that, or you probably know about this, and I can't talk intelligently about it, but somehow FHIR is going to connect us all together regardless of what IT platform you're on. And so I'm hopeful that something of that nature may simplify this as we go forward, but it's an issue today. We're trying. Others? Jenna?
With that, what you talked about with Cerner and how the doctors were able to see more of the preventative type things, do you view a doctor's appointment looking completely different in the future than it does today, with maybe the time that it takes, or how much more energy and efforts they'll have to spend with the preventative measures?
Sure.